with that note, we will get started on grand rounds. Welcome everybody. I hope all of you are staying warm and safe, and be careful this weekend. I think we're supposed to get more icy storm on Saturday. So try not to utilize our own healthcare system as much as you can. With that, we have a special grand rounds today. Actually, I'm going to remind myself before we get to grand rounds, as a reminder, the Department of Medicine Education Day on February 28th is coming up. Please register. We've got the QR code, and then Catherine can put the actual link in the chat. We've got a great day starting with grand rounds, breakout sessions, etc. Very excited. Hope to see all of you there. And with that, I'm going to transition to Dr. Vasilevsky, who's our Division Chief of Hospital Medicine, to introduce today's Grand Round speaker, Dr. Blair Golden from Hospital Medicine. So Ed.
Great. Well, thank you for that. So good morning, everybody. We're very pleased to have Dr. Golden present Grand Rounds this morning. Dr. Golden, as many of you may know, but if you don't, she received her Bachelor of Arts from Yale. This seems to be a family tradition. And she did her medical degree at UNC College and School of Medicine. She then did internal medicine training and a chief resident year, as well as a MS in health services research at Northwestern University. She subsequently spent a short period of time at Hopkins, and we were very fortunate to get her up to University of Wisconsin. Her research focuses on improving hospital-based care for adults with dementia who are at risk for delirium through improved partnership with family and caregivers. And a big part of that is communication, for which we're going to learn some about that today. She is a recipient of a NIA K23 Career Development Award that examines hospital communication and practice gaps for patients with delirium superimposed on dementia. For her work in delirium, she's received a Junior Investigator Award from the American Delirium Society, which is the premier research society for delirium and cognitive impairment. She's currently the Director of Academic Development within our Division of Hospital Medicine, serves on multiple national committees and the Research Committee for the Society of Hospital Medicine and the Society of General Internal Medicine. She's on the Academic Hospital Commission. So she is truly a rising star in hospital medicine, one of the premier researchers in the nation, and we're thrilled to have her and hear from her today. So good morning and welcome, Dr. Golden.
Thank you so much. I really appreciate that. And thank you all for joining today. Great to see some new and kind of familiar names in the chat. So today we'll be talking about teaching practical communication skills in the hospital. And specifically, we'll be talking about some concrete strategies that we can use when we're at the patient bedside to both role model and teach best practices. The focus today is on the hospital setting, but truthfully, much of what we're talking about today can be applied in the outpatient setting as well. And the reason I wanted to talk about this topic was really twofold. First, I think we all kind of recognize that communication skills are an essential part of being an effective clinician. But when, at least personally, when I actually think about how do I evaluate that or role model that or teach that in the context of being on busy clinical ward settings, it can feel a little bit vague and quite frankly can get deprioritized in the context of everything else I'm thinking about doing both clinically and in terms of education. The second reason I wanted to talk about this today is that much of the communication skills training that we receive is on very specific clinical scenarios, things like goals of care conversation. And while it's absolutely essential to be prepared for these high stakes scenarios, much of the communication we do with patients and their family members on a daily basis is on a lot of more mundane things. Things like what tests can the patient expect for the day? When can they leave the hospital? And I think it's equally important that we think of critically about how we can be effective in those scenarios as well. So what we'll be doing, first, we're going to start by talking about a little bit of background about why it's important that we think about effective communication with patients and their families in the hospital. And then we'll be spending the bulk of the time talking about several strategies to use at the patient's bedside. Specifically, we'll talk about the concept of etiquette-based medicine and some strategies related to that. And then we'll talk about types of medical jargon, how we can identify it, and strategies to reduce its use. So let's start with the first objective of why this might be important. I want to first acknowledge that communicating with patients and their family members when they're in the hospital can be really tough. Shown here is a representative illustration of some of these challenges that come to mind, but I'm sure you could probably think of others as well. We work in large, complicated, transient clinical teams with both primary and consulting services. Patients in the hospital are really sick, so with that comes a lot of data, rapidly changing clinical decisions and scenarios, and patients may have delirium or other conditions that limit their ability to communicate with us. There's oftentimes multiple and complicated family members involved in care, and we're coordinating communication both with those in person as well as those remotely. And then finally, our systems oftentimes simply aren't well optimized for us to communicate effectively. This includes everything from like the constantly beeping IV pole in the room that even when I try to turn it off, it still kind of manages to come on again. And I find it hard to kind of focus on what I'm saying, but also things like universal masking, which can make it hard for some of our patients to hear us, as well as the fact that patients are oftentimes missing assistive devices, things like hearing aids that they rely on to communicate with us. So recognizing these challenges, I still think it's important, and in fact, maybe even more important than ever, that we think about how we can kind of prioritize and improve our communication. Although this is disheartening, I think I would be remiss to not acknowledge that trust in the healthcare system, and that includes both clinicians and hospitals, has been on the recent decline. And while some of that may be COVID related, the trend is still continuing. So what's shown here is data from a large national survey where they assessed participants' trust. It was over 100,000 individuals repeated at multiple points in time. And what you can see here from 2020 to 2024 was that trust basically consistently declined. In fact, the overall percent of people that reported a lot of trust in the healthcare system went from 71% to 40%, so less than half. The data shown here is stratified by gender, but when the authors looked at other demographics, things like age, race, there were similar trends, unfortunately, across basically all groups. However, there are some things that we can do to combat mistrust, and particularly patient-centered communication may be an effective strategy. So in another large national survey, they found that whether patients perceive that their clinician used patient-centered communication skills, we'll talk about several of those throughout the course of this talk, had a fairly potent association with whether people trusted physicians as an information source, as opposed to, say, online or elsewhere. Admittedly, no, though, there are a lot of things that are not perfect right now in the healthcare system. And so I think we do have to consider how do we prioritize improving communication, which might be important, with everything else that could potentially be a focus. The IHOPE study, or Improving Hospital Outcomes Through Patient Engagement, was a large PCORI-funded study that was aimed to kind of identify the top research priorities to really advance the field of hospital medicine moving forward. They incorporated input from hospital medicine clinicians, researchers, leadership, but also had a very robust process for incorporating patient and caregiver input. And what they found was that most of these priorities involve fundamentally improving how we communicate. This involved things like improving shared decision-making in the hospital, explaining hospital diagnoses, providing clear discharge information. It even included things like whether we clearly communicate hospital policies around things like parking and visitor hours. I want to pause here to acknowledge that not all of this communication can or should come from physicians or advanced practice providers. That's what I'm focusing on today, given today's audience, but that a lot of the kind of heavy lifting and bulk of communication is being done by other members of the team as well, including nursing, pharmacy, and other team members. So what do we know about how we're currently communicating? One thing that's been shown across multiple studies is that hospitalizations are generally not well understood by patients. But furthermore, patients and clinicians may not be aware of this. For example, one study found that in a survey of patients, 96% said they understood shortly after discharge their hospital diagnoses. However, when they compared this to chart review, only 60% were able to name their diagnoses correctly. There's been other studies looking at similar kind of metrics, and truthfully, the 60% is actually on the high side. In many studies, this is less than 50%. I will say, admittedly, why someone's in the hospital and a diagnosis might be relatively complex. And I think that that could potentially be a high bar for patients. However, in other studies, there was work done by Kevin O'Leary at Northwestern. They found that less than a third of people could even name a hospital clinician that was on their team. And so I would argue that other data suggests that some of the more basic fundamental elements of what we're doing on a daily basis, they've looked at things like whether patients understand what tests are ordered and so forth, are not being communicated well, and there's room for improvement. Furthermore, suboptimal communication can contribute to patient harm. There's been a lot of studies looking at whether patients understand, for example, their discharge instructions and looking at things like readmissions rate. But one study that really resonated with me, in part because it focuses on exactly what happens during a specific hospital stay, was that hospital patients who have physical communication challenges, which the authors defined as conditions such as dysphagia or requiring a hearing aid due to hearing impairment, face a 3 times higher risk of preventable adverse events while they're in the hospital. We know that patients with these challenges often, unfortunately, receive inequitable communication, but I think this underscores the fact that communication in the hospital can have more proximal and direct impacts on patients' health. Finally, the rabbit shown here is meant to represent what I oftentimes at least feel like I look like if I don't actually look like when I'm on service. So if you haven't seen Alice in Wonderland maybe recently, this is a rabbit who basically feels like they have other places to be and says they don't have time to talk. You know, they say no time to say hello, goodbye. And oftentimes when I'm on service, even when I literally have nowhere else to be, I feel this kind of sense of like rush and that I need to kind of somehow be very mindful of my time. And if I only had kind of more time, I would somehow do a better job connecting with patients and their families. However, I would actually push back on that notion and say that this is actually not true based on the literature. So there was one study in which they looked at inpatient medicine teaching services, and they found that 74% of patients did not agree with their clinical team on their chief diagnosis or why they're in the hospital. I would argue that's not surprising based on other literature. However, when they looked at how many minutes at the patient's bedside they spent talking to the patient, even when they adjusted for patient characteristics like clinical complexity, there was no association between the time spent at the bedside and whether the patient and the clinical team were in agreement about why the patient was there. The takeaway from this is not that you should not spend time at the patient bedside. I don't want that to be the point. We absolutely do need to spend time at the patient bedside. But I do think it argues that simply being like, if only I had more time, I'll just spend more time, rather than actually thinking about how do we use that time effectively, is a misconception. So with that, we've talked a little bit about why might this be important, and specifically that patients and caregivers prioritize communication. It may improve trust and other health outcomes, and there's room for improvement. And now we're going to transition to talking about a couple strategies that we can use for effective communication. And as someone who studies healthcare communication, and we're going to be reviewing some of the literature on this, I think it's first important to acknowledge that communication is a complicated thing in real world, but also to study, and that we need to kind of think about it critically. And so we're going to walk through a framework that's by Richard Street, who's done a lot of work linking health communication to health outcomes to kind of set a primer for some of the studies that we're talking about. So first, communication itself serves multiple functions. This includes things like information exchange, but also fostering and building relationships. And those communication functions can sometimes lead directly to improved health outcomes. Health outcomes might include things like disease survival, but also things like emotional well-being. So what are some examples of scenarios where this might be the case? I think about like a surgeon who's in the operating room who tells someone not to ligate a blood vessel and stops them from doing that they're not supposed to ligate, or when I tell my kids to stop roughhousing with each other. Most of those times, those communications, I believe, have a direct improvement in someone's health outcome. However, I will say in my own clinical practice as a hospitalist, I don't always see that the communication that I'm doing has a direct impact on someone's health. However, that might be because communication can have other positive impacts, including more proximal outcomes. These include things like patient comprehension, but also trust. And those proximal outcomes may improve health outcomes, but they also may lead to improvements in other intermediate outcomes, things like self-care skills or access to care, that in turn can improve health outcomes. So I bring this all up for a couple of reasons. First, I want to acknowledge that most of what we're going to be talking about today has to do with communication and its impact on proximal outcomes. It is really challenging to link communication directly to health outcomes. However, there is, good evidence to suggest that some of these proximal outcomes do in turn lead to improved health outcomes. Second, we'll be talking about a bunch of different outcomes today, including things like patient satisfaction, trust, and so forth. That's because communication influences a lot of things. And so as we go through studies, I'll try to be very specific about what outcome the authors were looking at. So with that, we are going to transition to talking about the concept of etiquette-based medicine and some strategies to promote these behaviors. And as we go through different strategies today, we're going to think about it through the lens of a representative case. So our patient today is Dr. T, who is an 82-year-old retired physics professor who has chronic kidney disease, history of multi-drug resistant UTIs, who presented to the emergency department with fever, malaise, and fatigue. He underwent workup in the emergency department that was consistent with a urinary tract infection, an AKI, started on antibiotics, given fluid, and was admitted to general medicine overnight. So as you're hearing about the patient the next morning, whether you're the general medicine attending or potentially someone seeing them on as a consult service, you're thinking about what can you do at the bedside when you're talking to the patient to role model best communication practices for the learners on your team. And you can take a moment to think about that. As you do, I'm guessing that the first thing that pops in your mind is an etiquette-based medicine. Admittedly, I do not love this term, but I think the concept is a cool one. When I think of like etiquette, I think about Emily Post or cotillion or maybe some kind of a little bit outdated concepts. However, the concept does not come from Emily Post, but rather from the New England Journal. So in 2008, Dr. Michael Kahn, who is a psychiatrist, wrote this perspective on etiquette-based medicine in which he was reflecting on an interaction between a trainee and a patient where he felt like the communication was, let's just say, suboptimal, and was reflecting on how checklists had been used in other areas of medicine, things like reducing infections and central line insertion, and whether or not similar checklists could be applied in teaching trainees communication skills. Now, you might bristle at this idea. I think procedures versus communication, there are some differences, and that communication can feel, it's intrinsically a humanistic interaction, and is it amenable to checklist? However, the argument that he makes was that training for an etiquette-based approach to patient care would complement rather than replace efforts to train physicians to be more humane. He goes on to say, I may or may not be able to teach students or residents to be curious about the world, to see things through patients' eyes, or to tolerate suffering. I think I can, however, train them to shake a patient's hand, sit down during the conversation, and pay attention. Such behavior provides the necessary, if not always sufficient, foundation for the patient to have a satisfying experience. Furthermore, it's simpler to change behavior than attitudes. And I think this is an interesting thing and something I've struggled with a bit because I do think that it is absolutely essential that people in medicine do cultivate skills of compassion and empathy. But I think the argument that Dr. Kahn makes is that that might be really challenging for some people and that it's important to set the bar somewhere, especially for people who may struggle with some of those higher level skills. So what he proposed for what a checklist might look like for someone meeting a patient for the first time, and this could, again, be applicable in either the outpatient or inpatient setting, is to knock or ask to enter the room, to introduce yourself, to shake the patient's hand, and I think maybe some of that etiquette has changed recently, to sit down, explain your role, and ask the patient their feelings. Now, what you might be thinking, at least I especially thought this at first, is that this seems like a little bit of a low bar and that isn't everyone kind of always doing this all of the time? Or alternatively, if someone isn't doing these behaviors, it seems like maybe there's a very compelling patient-specific reason why it might not be appropriate. Well, it begs the question of how often are these behaviors being done? And there's actually a group from Hopkins that did a study looking at this. They went and observed more than 200 clinical encounters with different patients in hospital settings. They chose 24 random hospitalists across 3 hospitals. Some were more academic, some were more community. And they didn't tell the physicians, they were all attending hospitalists, the purpose of the study. They said it was a time motion study and they were going to see how they spent their day on rounds. What they looked at was whether or not the hospitalists completed those 6 etiquette-based behaviors and whether completion of the behaviors were associated with patient satisfaction or either workday factors. So things like having a lot more patients were you less likely to complete the behaviors. So here's what they found. And again, they only looked at the first encounter between a hospitalist and a patient for a day. And they separated out new patients who the hospitalist was meeting for the first time versus all patients. So let's go through the data. So what you can see is that hospitalists do pretty well, more than about 80%, introduce themselves to a patient that they're meeting for the first time. But from there, it quickly kind of goes downhill, and that no other behaviors were done most of the time. And in fact, for about a third of patients, none of the behaviors were done. Furthermore, there was no association with factors, including the number of patients. So it wasn't just that people that had a higher patient load were less likely to do this. Furthermore, amongst those that completed these behaviors, the total number of behaviors completed was positively associated with patient satisfaction, as assessed through the use of Press-Ganey communication score. Interestingly, however, when they looked at individual behaviors on the checklist, sitting down was the only one that on its own was also associated with patient satisfaction. So why aren't people regularly doing this? What the authors conclude, which I think makes sense, is it's not clinician knowledge, but rather things like system and environmental factors that are leading to these observed behaviors. These system environmental factors might include things like the sense of feeling rushed due to everything else that's going on, how rooms are set up, which then begs the question of how do we shape our system so that we can do some of these effective communication behaviors that I think we all kind of have a sense that we'd like to be doing on a daily basis. So here I'll transition to talking about some of the work that I have led on this topic. And specifically, when I was on faculty at Hopkins, I had the opportunity to lead several projects focused on promoting sitting at the bedside by internal medicine residents. And I was interested in this topic really for several reasons. First, sitting at the bedside has been associated with multiple benefits. We saw previously the data on patient satisfaction, but other literature has included positive associations with things like how much time do patients think that we're spending at the bedside, explaining things in a way that patients can understand, listening carefully. I would argue all 3 of these are really critical to patient communication skills that in turn instill trust. And then furthermore, we all kind of develop habits and training, whether it's medical school or residency, that stick with us throughout the rest of our careers. And so I was interested in this idea of thinking about how we shape kind of good habits early on that will kind of stick with clinicians for years to come. So the first thing we did was survey general medicine inpatients and medicine residents about kind of current sitting practices and attitudes towards sitting at the patient bedside. We did a patient survey of patients who were admitted to the general medicine teaching service for at least 2 days, who were able to complete surveys in English, and were able to recognize photos of either the intern resident or senior resident on their team. We only surveyed patients if they could specifically identify a clinician that was taking care of them and kind of answer questions about that clinician's behavior. Surveys were administered in hospital rooms by trained administrators, and we asked patients about how often individual residents sat when visiting the patient bedside, as well as the frequency of other communication behaviors, things like whether or not the resident seemed to be in a rush, seemed to be checking for understanding, and so forth. In parallel, we did a resident survey of all internal medicine residents via email. We asked residents, how often do they think they sit when they're visiting patients' bedsides, as well as perceived attitudes towards sitting, namely barriers and facilitators. So what we found, so in the patient survey, we had 256 patients complete a survey of a variety of interns as well as senior residents. Only 13% of patients said that resident physicians frequently sat when they visited the hospital bedside, defined as most of the time or always. However, amongst those residents who did frequently sit, they were associated by patient-reported improvements in always spending enough time at the bedside, always checking for understanding, and never seeming to be in a rush. In parallel, again, we did this resident survey. We had about a 51% response rate, and we had about a third of residents, which is not high, but higher than what patients say that they felt like they frequently sat. We asked again about barriers and facilitators, and one thing that came out in the barriers, the two most common reasons why residents said that they didn't frequently sit, one was that chairs weren't available, and second was that there is a chair in a patient's room, but it's covered in something. And so I always think about we've all been in the patient rooms with the recliners, and there's like the plastic bins of medical supplies. This is what this is referring to. And then only 3% said it was because their attendings didn't emphasize it enough. So based on this data, we did a chair intervention. We installed chairs on 2 out of 4 medicine units at Hopkins. And so basically at Hopkins, there's 4 identical medicine units. They all have the exact same layout. However, residents at the beginning of intern year are randomly assigned to one of 4 firms. And each firm only rotates on one of the 4 medicine residents. So effectively, residents only rotate on one of these units throughout their training. Shown here is a picture of one of these chairs. We put them right as you walk in the door to serve as a nudge. We labeled that they were specifically for clinician use. And then we made sure to have a place, like a hook on the wall, as you can see, so that the chairs would have somewhere to kind of stay and not run off in between use. We also did, in parallel, brief education for all residents that everyone got, regardless of which of the 4 firms or units they rotated on, consisting of a new conference, presentation, some team room flyers, and then some education for the chiefs on promoting sitting. We thought going into this that chairs would increase sitting beyond education alone, and that chairs would also be associated with other positive improvements in communication behaviors. So with that in mind, our primary outcome was looking at the change in the Likert score from never to always for sitting frequency. And then we also had several other secondary outcomes we looked at relating to communication behaviors that were the same behaviors from our baseline survey. We intended for this to be a 1-year academic project. We started at the beginning of kind of summer 2019, surveyed throughout the late fall, installed chairs in late January, and our plans to do our follow-up surveys in February, March of 2020 did not come to fruition due to COVID. And so we ultimately resumed surveys in late 2021 when it was safe to do so. By then, most of the residents had graduated, and so everyone got the same repeat education. And this, because this is real world, had some implications for our statistical plan. But what I'll show here is a repeated measure ordered logistic regression. It accounts for if there's multiple surveys about one resident. And then we did a difference analysis of the change from baseline for the units that got chairs versus those that only got education. We also compared the immediate versus later time frame in the post intervention period to assess for any decay from the educational intervention. So what we found here, anything that's a statistically significant change will be shown in light blue. And again, these are mean Likert scales ranging from 1, which is never, to 5, which is always. So we did find that the educational units had a small increase in the sitting frequency, but that the units that got chairs had a much larger, I would argue, statistically and kind of real world significant increase in sitting frequency. We also found that the units receiving chairs had statistically significant improvements in whether patients reported that residents spent enough time at the bedside or checked for understanding compared to those units that only received education. Interestingly, we did not notice a change between the 2 groups of units and whether patients reported that clinicians talked without interrupting or appeared to be rushed. They appear to be rushed. Again, it's a low number because it's you want to have people never doing that. And we suspect that that was in part because both of these behaviors residents did really well at baseline, and so it was hard to enact much change. Finally, we didn't see any decay over the 7-month survey period in either group. And then this is unpublished data, but one thing that I thought was interesting was that we did a follow-up survey with residents, and residents on education-only units were much more likely to report that a lack of chairs was a barrier to sitting, 68%, compared to units receiving chairs, although we still had 22% of residents saying that lack of chairs was an issue, so we didn't totally fix the problem. There have been several other studies focusing on clinician posture, both in the inpatient and outpatient clinic setting. There was actually even a recent review that was focused on the inpatient setting that came out in the past year or so. And while many of these articles have limitations, the authors from this review still concluded that we should try to make an effort to at least get on eye level when we're talking to patients and their family members and hospital. Admittedly, this can be tough. We're actually very lucky at UW, at University Hospital. There's long been kind of folding chairs in hospital rooms, but it can still be hard to actually implement this in practice. And so some of the things I try to do in my real world practice when I'm on teaching rounds is to try and kind of adjust my posture to get on eye level, even if there's not chairs available, to bring the chairs to trainees who are leading the conversation, and then to prioritize sitting and focusing my posture on some of those encounters with more in-depth conversation. I know there's other creative strategies out there. Some people who are really committed to the cause have bring like folding stools and so forth. And I have not done that yet, but I think, again, this can take some creativity, but has been shown to have some benefit over many different studies. So with that, getting back to our objectives, we talked a lot about sitting and how it relates to etiquette-based medicine. However, I did promise strategies plural. So I want to kind of talk about some of the checklist strategies that aren't just sitting, since I think it's important to acknowledge it's not the only element of the checklist. And specifically, as I've transitioned to my faculty role at UW, I've actually become much more interested in at this last kind of element of the checklist, which is asking the patients about their feelings. And again, I don't love how this is phrased. Feels a little fluffy to me. And I don't think that necessarily talking about feelings is something that intrinsically always resonates with me as a clinician. I think oftentimes my job is to advance a patient's plan of care rather than to just focus on feelings. However, I would argue this is not really just about feelings, but really about understanding what a patient's priorities and values are. And that is absolutely essential for me to be an effective clinician, especially as I'm thinking about care planning, discharge planning, and so forth, to understand what a patient's goals, priorities, and values are. And this is perhaps not surprising, but we don't actually do a great job at all in the hospital setting with this currently. So there was a study that interviewed 1,850 patients across 7 countries, and they asked them, what matters to you? Do you feel like your clinician knows this? Perhaps not surprisingly, over half said they felt like their hospital clinician did not, in fact, know what mattered to them. When they asked patients what matters, there was kind of some consensus around top things that were important. Things like getting better, getting home, having a diagnosis. Arguably not surprising. However, when they then asked patients, well, why does that thing matter to you? The word cloud is shown here. There was not a clear consensus at all. In fact, people gave very diverse answers. Things like from family and friends, but also you can see like care burden, anger, work. And so I think that argues that if we're not intentional about soliciting this, we're not also going to be effective in terms of thinking about how we actually construct care plans that are well aligned with patient and family values. Furthermore, understanding what matters is increasingly being recognized as a key component of what's called an age-friendly health system. So the age-friendly health system is an initiative promoted by the John Hartford Foundation in collaboration with the AHA and IHI that's organized around this thing called the 4Ms framework. They're shown here, one of which is what matters. This is meant to improve geriatric hospital care, but honestly, or actually outpatient as well, I should say, but I think most of these considerations are applicable to all of our patients that are in the hospital. And furthermore, as of January 1, there is a new CMS age-friendly hospital measure as of the inpatient kind of hospital quality reporting program, in which hospitals are going to be kind of assessed on whether or not they can demonstrate that they are regularly eliciting and documenting patients' healthcare goals, specifically through this kind of what matters framework. I think it's one thing to kind of ask someone what matters. I think where there's really more work to be done, and I think what excites me for the future is how we translate this communication into actual action that meaningfully influences the patient's care plan. I've had the opportunity to collaborate with Kari Hervella at UW, who's one of our fabulous geriatric CNS specialists, who's really led and spearheaded our age-friendly work, as well as Elizabeth Chapman from geriatrics, to think about how we operationalize some of this. And currently at UW, so our nurses routinely, for example, ask patients over 65 what matters most to them. If you want to see this on your pre-rounding, you can actually add it to your EPIC list as kind of a column similar to kind of service or room number. I don't think this is just a nursing question. That is not the takeaway. But this is a recognition of how important this is. I think as we think about next steps, one goal is to think about how we translate this information into clinical plans. And again, this is not just a local consideration. There are lots of people doing kind of national, international kind of thought work on this. And so I think more to come, but area of future interest. Finally, the last thing I'll say about the checklist is that I think there is one critical thing that it really has not included, and that is acknowledge and integrating caregivers into care plans and communication. Caregiver communication is, quite frankly, essential at the hospital bedside. In studies of patients who are in the hospital, they've been asked about what are benefits of having your family member present on rounds and kind of talking to the clinical team. And patients have identified a number of benefits. This includes things like translating medical concepts, not serving as interpreters, between the patients and team, helping patients understand and remember care plans, providing information when a patient's unable to communicate, whether it's due to delirium, fatigue, or other conditions. And then finally, whether we like it or not, one of the identified benefits from patients is that they push back or challenge clinicians' treatment plans. So the things I would add, if it were my checklist, is to make sure that we're intentionally kind of asking patients for visitors. If there's someone in the room, we see what the patient's preference is for who that person is, should they stay, introduce ourselves, and especially when someone's not there, always asking every day, who would you like me to update about your care, and making sure that that's something kind of on our checklist that gets done. Again, I think that we all know that we should be doing this, but this is something that in the hustle and bustle of everything else that we're doing oftentimes falls by the wayside, which I think is really unfortunate. So with that, we'll go back to our case. So your team has kind of reflected on the checklist, and based on that, you asked your patient about their concerns and priorities, and learned that one concern is whether he'll need outpatient IV antibiotics, which he's required in the past due to some complicated multi-drug resistant infections, given he has some upcoming planned travel. So you're able to kind of talk about formulating a plan to clarify if that's needed, who you'll touch base with, incorporating relevant consultants, pharmacy, and so forth. You also confirm that you should update the patient's spouse via phone. However, reflecting on your rounds, and you're thinking about what kind of you said and what maybe the learner on your team says, you wonder whether there's other feedback that you could potentially provide regarding communication. For the sake of this scenario, we'll pretend that maybe you were the general medicine attending as opposed to a consultant, and here's what was said. So first, you introduced yourself to the patient, said, hello, I'm the hospitalist attending on the general medicine service. I will let the senior resident explain the plan for your admission. To which the resident said, Dr. T, given you are febrile in the ED, we've admitted you for a suspected infection, and we've done some workup to determine the potential cause of this infection. We see some bugs in your urine, so suspect you have a UTI. Your chest x-ray was unremarkable. We plan to treat you with antibiotics, we'll also watch to make sure your blood cultures remain negative. So you're thinking about maybe what could be done better here. Arguably, I would say that there's many things that were done well here, but one area that I think can be improved is the use of jargon. And so we're going to talk a bit about how to identify types of medical jargon and strategies to reduce its use. So first off, jargon is common. We all use it. There was one study looking at pediatric inpatient teaching rounds, and they found that on average, there were more than 4 unexplained jargon words per individual patient rounding encounter. Furthermore, we use jargon even when we know we're being watched about whether we're using jargon. So there was a study looking at a communication skills training about jargon. They surveyed internal medicine residents, and almost 90% said they frequently use simple language rather than jargon. They then observed them in a standardized patient encounter. Again, it was disclosed that this was about patient communication and jargon, and found that on average, residents used 2 jargon terms per minute, of which only half were explained. This is not to pick on trainees. I've chosen trainee literature for this example, but if you look at similar literature for attendings, it's all the same. This is ubiquitous. So why is jargon problematic? And specifically, how do patients interpret jargon? So there was a group from University of Minnesota who did a survey of 215 adults recruited from the Minnesota State Fair. They have a tent there. And these participants were well educated. Most had a college degree, but they had no medical experience or training. They assessed people's understanding of common jargon phrases. And then as secondary aims, they looked at whether people had differences in verbal or written communication. So does it make a difference if the phrase is said to somebody versus they have to read it, as well as the impact of demographic factors on comprehension. So how commonly do people understand these common phrases? I've bit arbitrarily grouped this into more than 90% understand a phrase, which I say is pretty good, 50 to 90, which is not perfect, but most people understand, and then less than 50. So what they found is that more than 90% understood the phrases, your blood test showed me that you do not have an infection in your blood, and your cancer screening test came back and the results are negative. I would argue these phrases are a little bit wordy, but the vast majority of people understood this. From there, however, it goes downhill. So things that only 50 to 90% understood included your blood culture was negative, your chest x-ray was unremarkable, you are to have nothing by mouth after 4 p.m., and your nodes are positive. I'll highlight a couple things about these phrases. First, all relatively common things that I have said probably at some variant on rounds. The second thing, though, is that you can see how relatively simple changes in how you phrase something. So going from your blood test showed me that you do not have an infection in your blood to your blood culture was negative can have an impact on how much people understand it. Let's go to the phrases that most people did not understand. These include things like your urine tests are back and there were bugs in your urine. The findings on your chest x-ray were quite impressive. You will need to be MPO at 8 a.m. That was 11% of people understood. And then for less than 10%, have you been febrile? And I'm concerned the patient has an occult infection. Part of the reason I like this study is, again, these are not esoteric things for the most part. A lot of this comes up on our day-to-day rounds. It may not be things that we're even aware of. So the authors suspect that some confusion might be related to the use of words that have other meanings. So occult oftentimes means a curse. However, that is oftentimes not what we mean when we talk about an occult infection. Similarly, positive in most contexts means a good thing. However, when we're talking about a positive biopsy or positive nodes, it oftentimes has a negative connotation in medicine. Furthermore, there was no difference between verbal and written communication for most phrases. So it's not simply that people have a hard time reading things, but rather just that the phrases are confusing. Finally, demographics were not a consistent predictor of comprehension, which really underscores that we need to use clear communication for all patients. We oftentimes have very highly educated professionals at UW, but we can't make assumptions that people understand medical jargon simply based on their level of education. The same team did a follow-up study, which I like a lot, which is looking at how we describe ourselves and whether people understand that. They again surveyed over 200 adults at the Minnesota State Fair and asked whether people were familiar with medical specialties as well as physician roles. What they found was that certain specialties like dermatology and cardiology, most people understood. However, there were 6 out of 14 specialties that were understood by less than half of participants. This included things like pulmonologist, but also hospitalist and internist, and then nephrologist. You can make an argument that not everyone needs to know what a nephrologist is. However, I will say they've done studies looking at in like oncology and whether patients understand the multidisciplinary, very complicated multidisciplinary clinicians involved in their care, and oftentimes comprehension, even if someone may be seeing a physician or clinician, can be low. Finally, only 6% of people could identify the correct role order on kind of a traditional inpatient medicine teaching team. And senior residents were most often identified as the most experienced person on the team. And while I would argue that oftentimes the senior resident is the leader of the team, I don't think that we need to be communicating to our patients that they are the most experienced. So we've identified that jargon use is ubiquitous, it's confusing. The next question is, how do we reduce its use? Michael Pitt, who's done a lot of work on this, said, like many things in life, the first thing is recognizing you have a problem. And so proposed that a classification scheme for thinking about how we can identify and give feedback to learners on jargon use. This scheme includes things like that we typically think about jargon, so kind of technical terms, things like syncope, bilirubin, as well as the alphabet soup of medical abbreviations and shorthand, so things like CBC, NPO, and CAF. But what I like about this scheme is it also includes things that I may not typically flag as jargon, and I think the prior 2 studies have highlighted that jargon can be kind of a more inclusive thing, so I think it's helpful to actually have a framework. So this includes things like euphemisms, so things like expired or voiding that are neither helpful for patients, but also might be just quite frankly offensive. Also, the 2, which I think of as similar kind of concepts of medical vernacular and medicalized English. So medical vernacular are words similar to lethargic or inflammation that kind of entered the mainstream consciousness, but have a different implication when used in maybe a medical context versus like a real world context. So I think about as a new mom when I first got called from my kid's daycare that my kid was lethargic at daycare, and I freaked out. And I was reassured to see that kind of the teacher's interpretation, which I think is totally appropriate, of lethargic was different than mine as a medical professional. And so again, these words can have different connotations. Medicalized English includes terms that have the opposite meaning in medical kind of context versus real world context. We talked about positive, but also things that may have a different meaning in medicine. So things like tenderness, appreciate, impressive. And then finally, there's the unnecessary synonyms. So things like lower extremity, and you could just say legs or ambulating for walking, as well as the judgmental jargon, which really just doesn't have a place for patient communication, period. So now that you've kind of recognized it, the good news is that structured, regular feedback can help reduce jargon. So there was a study that looked at the impact of a communication report card on a group of pediatricians. So they randomized, I should say the study authors, there's a fun UW tie. The senior author is Dr. Phil Farrell, who's a former dean at UW, who wrote this with his son, who's a health services, health communications researcher. So they randomized a group of pediatricians to perform a counseling encounter about a genetic test to a group of standardized patients. They recorded that encounter and then gave the clinicians feedback via a report card shown here on their jargon use. This included things like how many total jargon words they did, how many words did they explain, and then they also gave them performance characteristics relative to their peers. I think this is an important point to flag, which is that it's not to say you should never use jargon. I cannot imagine explaining a genetic test without using some medical terms, but rather that it's important and critical to really explain these words and contextualize them when they need to be used. So what they found was there wasn't a change in the number of jargon words. However, there was a statistically significant, and I would argue clinically significant, improvement in the percent of jargon words that were explained from 30 to 55%. Of course, we don't always kind of have these report cards at hand. So how do we do this kind of in real world settings on the wards? So the group that developed the jargon schema actually made pocket cards and it published on basically taking those pocket cards with the schema and doing a real-time jargon audit on rounds. They gave learners feedback on their jargon types and use, and they basically said it was feasible to implement, but unfortunately in their publication, they didn't provide any data on process metrics or outcomes. But this is one approach. I think there's others. And in fact, one of the ideas that was proposed by Dr. Gretchen Schwartzy, who probably many of you know at UW is a surgeon who has done a lot of work in health communication, that I thought was fun and really creative, was could we make this, competitive game? And so she proposed, could you have a jargon bingo on rounds and kind of see if someone can win for the week? And I love this idea. I've shown here what would be my personal jargon bingo card of words that irk me, but I'm sure you can think of others. And so I do think there's kind of creative ways to make sure that people are getting this real-time feedback. Finally, one of the reasons I was motivated to kind of study this and think about this as a topic was in part because of one of my own attendings and the work he's done and how he brought this into rounds. So I had the opportunity to work with Dr. Robert Hirschtick for a number of months at Chicago VA during training. And Dr. Hirschtick has done several JAMA pieces in my mind reflecting on the use of jargon and other ways in which we communicate in the medical literature. And so what he would do, because he was always kind of had pet peeves when we used overly complicated words with patients. So why say bilateral lower extremities? You can just say legs. Would assign regularly a jargon monitor, whether it was himself, a resident, a trainee, to make sure that we were getting feedback on this in real time. And this wasn't to say that we didn't get feedback on other kind of clinical decision making, but the fact that our communication was really elevated to other things that we were getting feedback on, including physical exam, medication choices, really resonated with me in my training and something that I've taken forward. Furthermore, another thing that Dr. Hirschtick did is he's, I think, thought creatively, not just about jargon, but about how other kind of phrases, kind of medical shorthand that we say offhand in rounds in front of patients can maybe resonate with patients in ways that we don't intend. So he wrote a perspective on the quick physical exam in terms of kind of how we always will say on rounds, like, I'm just going to do a quick physical exam if that's okay, and how patients might perceive that. And kind of reflecting that patients, of course, are on the receiving end of the quick physical exam. What do they hear when they hear quick physical exam? I suspect quick is not heard as for your convenience, but rather cursory. It cannot be very reassuring to hear that one's physician ask permission to be cursory. And so again, I think intentionally bringing this kind of attention to what we're saying, what does it mean to our patients and their families, can really set a role model for kind of training that sticks with learners in the future. So with that, let's get back to our case. So you first start by reflecting on your own communication with the patient, and maybe there's things to be done that could be improved. So rather than saying, hello, I'm the hospitalist attending on the general medicine service, I will let the senior resident explain the plan for your admission. You could say, hello, I'm Dr. Golden, introducing yourself. I'm the attending doctor on the general medicine team, and explain that you supervise the resident physicians on your team. You then introduce the senior resident who will explain the plan for the day. Similarly, you give your resident feedback that potentially instead of saying that you were febrile in the ED, you could just say, given your fevers, rather than saying you have bugs in your urine and you have a UTI, which could be confusing. You could say that you have a UTI and clarify that that means an infection in your bladder, and simply say your urine test showed bacteria, which can be seen in these infections. Similarly, rather than saying your chest x-ray was unremarkable, you could just say your chest x-ray was normal. I will point out here that in both of these examples, clear communication does not have to be longer, can sometimes be more concise. And then finally, instead of saying we plan to treat you with antibiotics and we'll also watch to make sure your blood cultures remain negative, you could simply say we'll follow up on your blood test to make sure you do not have an infection in your blood. So as we conclude, hopefully you've taken away from today that improving communication is a priority for hospitalized patients and may lead to improved health outcomes. We talked about several strategies to improve communication at the patient bedside, including sitting at the bedside, asking patients what matters, intentionally incorporating caregivers, and recognizing and providing feedback on jargon use. I recognize that much of what we covered today is not rocket science, and it is partly because we oftentimes know many of these communication best practices, and yet it's really challenging to consistently do this in practice. We are balancing many things when we're on clinical service, and yet we know that patients and their families prioritize this. And sometimes I think thinking about being a good communicator can be overwhelming, and it's hard to know where to start. And so I'm hopeful that you've taken out some concrete strategies from today. I reflect also on Dr. Hirschtick's essay on the kind of quick physical exam, in which he was talking about how kind of doing a regular good exam can be challenging. And I think what he writes is analogous to communicating as well. And so his kind of words are my advice to clinicians seeking to improve: think Nike, just do it. Don't aim for Holmes' expertise, aim for Watson's competence. We all can and want to be the physicians masterfully leading goals of care, complex conversations, and we can do that. But I think it's also important that we're intentional about on our daily practice, how we think about effective, good strategies as well. So with that, I hope that you can take away today and commit to one strategy that you can intentionally integrate into your practice, particularly next time, whether it's later today or in the future, that you're working on the wards or in the outpatient setting with learners. I'd like to thank the many people who provided feedback on iterations of this talk, including patients and caregivers, as well as my Hopkins research team and research mentors. And with that, happy to answer any questions.
Great. Thank you, Blair, for really a wonderful overview. You hit upon a few of my pet peeves, and particularly jargon. And I will take chair prerogative, chair as I'm chair of the Department of Medicine. And Alice, you've been focusing on using jargon in how we deal with patients, but how shouldn't we, or could we incorporate that into how we interact with our medical students? And part of it, I'm reflecting back when I was a second-year medical student. I still have a vivid memory of sitting in a classroom with a couple other friends of mine. We still talk about it. And the radiologist is talking about ticks in the colon. And we're looking at each other going, how did those ticks get in the colon? What happened? So how do we talk about this type of thing in our education and educate our students early on?
Yeah, no, I think it's a great question. And I think, one of the advice I give my students is like, there's a little bit of kind of learning the terms, but also kind of to be very intentional as you're kind of developing your almost like patient scripts for things that you're talking about, that you almost have to be able to kind of in real time kind of translate between these medical and non-medical concepts. And so I think the more intentional we can be about recognizing jargon up front, that can help as well.
Yeah, I guess I'm thinking of how do we train our educators not to use jargon when teaching medical students?
Yeah, I mean, I think again, this talk was kind of thinking through the lens of trainees, but I also think that I need feedback. We all need feedback on jargon use as well. I know that I do this. One of my kids called me out on using medical jargon not so long ago. And so I think part of it is having feedback systems in place for medical educators, because again, we all do this.
Great.
Blair, I had to highlight the irony that you mentioned that this is not rocket science, but some of the biggest rocket disasters in history have been due to communication failure. So just highlighting communication really does have safety importance. I'm curious, your checklist that you proposed with regards to the caregivers, do we know how well we do with that? How often we are contacting family members, how often we're asking about them or asking permission in the room to speak to whoever's in the room?
Great question. So there is who has been the most progressive in this literature is pediatrics, where there is really interesting and innovative work being done on this concept of family-centered rounds. As part of preparing for this talk, I was really interested in this idea of kind of how our family members integrate it in adult rounds, particularly outside of the ICU setting, where I'll say there's some, and in the general medicine wards, it is really not well characterized. There's kind of family qualitative studies of what do families perceive, but I don't even think we have a baseline performance benchmark of how well we're doing this outside, again, studies that are settings that are more focused on it, like ICU.
Great. There's a few questions in the chat. One, I think, is the use of whiteboards was commonly publicized as something that was key of importance. And so can you lead us in terms of how we should use them or if we should use them?
Yes, there's been, I think so. There are some smaller studies looking at whiteboards and kind of using them to update on kind of clinicians and plan of care. I think in the right context, they can have some benefit. The challenge has been that the studies have been done as kind of small QI initiatives. And so, as you know, like I go in the room all the time and like the whiteboard's not updated and who's updating the whiteboard and like and so forth. And so, again, I think with any of these systems, they can work if we are committed. They can be beneficial if we're committed to doing them and making it happen. The problem is like oftentimes this is like the broader issue with communication is we're doing like 10 other things and the whiteboard inevitably falls at the wayside.
And I'm going to paraphrase or expand on one of the other questions. You didn't talk about computers and walking into rooms with computers or our team working on their iPads, etc. How is that impacting communication and thoughts on that?
Yes. So that was actually one of the big concerns that came up in our resident survey of why are you sitting or not sitting? And they're like, it's all about where the computer is in relation to the hospital kind of room and so forth. I will say at UW, we're less likely to, oftentimes we don't have computers as much in the hospital rooms, but what they've done actually in the outpatient setting, there's been studies of this. And what they found is that for patients, they don't always mind if you're on a computer. They understand that it's like an information source and they want you to be using that information. What does matter in terms of patient perception is whether you can maintain that eye contact. And so basically, can you adjust your body posture, take kind of breaks and actually make it an effort to like look at the patient? That's what makes a difference. So it's not to say never use a computer, but again, be mindful of your body posturing and how you're engaging with the patient and the family while doing so.
Maybe to combine this with another question about how to make chairs more accessible. As someone in the ICU where we do walk around with our, I guess they're wows now, instead of cows. What about, and chairs are rate limiting in the patient's room because family members, stuff is on them, etc. Could you develop the computer cart with a attachable, I like the foldable little stool with the computer, so you could
Yeah, I think there's lots of room for innovation. And again, I oftentimes feel like when I'm able to like actually sit down and have like I feel like more relaxed when I'm leading the clinical conversation. So I think there's multiple benefits in terms of some of these innovations.
Yeah, maybe we should have like Department of Medicine branded little portable stools we could bring around.
Love that.
Great. We are over time. There's some other great questions. I love Carrie's question also, which we will continue to address. So thank you, Dr. Golden, for a really practical, pragmatic talk about how we can improve patient care in the inpatient and applicable to the outpatient as well. And look forward to having less jargonized conversations as we move forward. I suppose jargonized is a jargon itself. But
Thank you very much. I appreciate it. Thank you.